Hi guys, Dr. Gillard here once again with another YouTube video. Finally, I've done it. At long last, I've created a YouTube video that is dedicated to the cervical spine. This video will be the first, hopefully, in a series. The next one after this will be how to read your cervical MRI. But before you can read your cervical MRI, you have to understand the unique anatomy of the cervical spine. So that's what we're going to cover in this video. Specifically, we're going to talk about the osteology of all the bones. There's 7 bones in the cervical spine, including atlas and axis. We're going to talk about the muscles and particularly about the ligaments. I'm going to hit the ligaments a little harder. I'm not going into origin and insertion and things like that. It's not going to be that deep. We'll talk about some basic neural anatomy, specifically about the difference between nerve rootlets versus, say, sensory nerve root versus a spinal nerve, dorsal root ganglia, anterior ramus, posterior ramus, medial branch, things like that, that kind of anatomy, just to sort that out. Then we'll talk about the cervical disc. I put together a little cartoon series on how a disc goes from a normal disc to a degenerated disc to an annular tear to a disc herniation, and a bunch of pathology we'll cover. And in fact, let's look at that a little more closely here. So there's the table. I at least gave you the slides. I'm going to leave this all intact. I don't think I'm going to break this down. But there's the things that I went over and where they are. And then pathology is scattered throughout. I didn't have time to pick the slide numbers out, but we'll talk about cervical ribs versus hypertrophic transverse processes, about a kyphotic. I'll show you an example of a kyphotic cervical spine. We'll talk about some biomechanics. Uncovertebral joint hypertrophy. Many of you have never heard the word uncovertebral joint in your lives, yet I have clients who have ended up getting cervical surgery to fix problems like that. So we need to talk about what that is, and I'll show you a recent case where one became severely degenerated to the point it caused radiculopathy even. We'll talk about a hemivertebrae really briefly, some stenosis, posterior ponticle, you probably don't even know what that is. And then we'll talk about some degeneration and some of its sequelae. Well, I already said that. That's going to be this in the cervical MRI section. We'll talk about annular tear and a herniation. All right, with that said, let's get moving. All right, cervical anatomy review. Now, I apologize in advance. My studio here is not super soundproof, and we have kids and all sorts of dogs, and everybody's shelter in place right now, right? So they're running wild, so I apologize in advance for any background noises you might hear. All right, so you need to understand, we explained this at the beginning, you got to understand the MRI of the cervical spine, or the gross anatomy, before you can understand what the MRI anatomy is. So this is really important. If you're not up to this, you probably shouldn't bother looking at your MRI images because you won't understand them. So let's start from the beginning. What does the cervical spine do? Well, it supports the head and the neck. There's a cervical spine right here. And yep, there's your brain up there and your skull. You can see the skull casing. And yeah, it's kind of a pole that your head and neck sits on. It also protects part of the central nervous system called the spinal cord. Spinal cord goes through the vertebral canal here. So that's really important as well. So we'll look at that. And it allows for motion when you turn your head to the right, when you turn your head to the left. How do you think that happens? It happens via the pole, which has 7 segments on it, and they can articulate and move. So it's super important. In fact, the cervical allows more motion than the thoracic or the lumbar. Here's just a CT I threw up here of a patient with a spinal fusion that didn't go so well. But this is a scout CT view. The point of this, though, you can see the head, you can see the skull quite nicely, and you can see right in the middle of that the neck, and there's the larynx and trachea. You can see right in the middle of all this, there's the cervical spine supporting everything. All right, some basics of the cervical spine. There are 7 bones. They're called vertebrae, plural. Each bone is called a vertebra. These bones are similar to lumbar bones that we've already studied, but they're much smaller. They're also stacked on top of one another to form a tower. If you look at the side view, there should be a lordotic type curve with a concavity posteriorly. We'll look at that in a second. If you look straight from the front or the back at someone's spine, cervical spine, just like the thoracic and lumbar, it should be straight. It shouldn't be bent off to the side. So here is a posterior to anterior view of, you can see the back of someone's skull. And here is a very straight and normal looking cervical spine. We could put that patient in a side view. Actually, I used just a standard radiograph here. Same picture, you can see the jaw would be coming out here, the nose is here, and the eyes are out here. But there's a cervical spine, and it has, from a lateral view or sagittal view, it has a curve like this. And you can say it's concave here on the back, or you could say it's convex on the front. So having a straight spine and a lordotic spine in the cervical region is very important. Specifically, the bones are designed to carry the weight of the head and the weight of gravity. And therefore, you have normal biomechanics, normal movement, and your ranges of motion, your planes of motion are not messed up with regard to load. But if you have messed up biomechanics, then you're going to have some problems. So if you have normal biomechanics, you have normal wear and tear, cervical spine should last a long time, barring injury. Abnormal alignment or abnormal biomechanics will lead to a wearing out, an unequal wearing out of the spine, and that creates something called degenerative changes. Degenerative changes are the root of pain-producing pathologies, aside from traumatic fractures and tumors and other things, cancer infiltration. Most of the time, pain in the neck starts from, there's a precursor to it, and it starts with some abnormal biomechanics, and that wears something out ahead of time, and that wrecks the disc and or the facet joints. So pain-producing pathologies, two general categories are degenerative disc disease, that's problems with the disc because it degenerated, or arthritis, aka spondylosis, spondylitis. These are all arthritis, just degenerative changes of the bones, namely the facet joints. Okay, here's that normal. This is a CT view now. So we have a slice right down the middle. That's why we can see the vertebral canal quite nicely here. But if you look at this patient, let's get you orientated. We'll learn about the dens is the best way to see which way is forward and which way is back. This is C2, or called the axis. This pole-like looking structure, which we don't see anywhere else, that always goes forward. And you can see the oropharynx is here. You can see the epiglottis, the larynx, trachea is here. That's another way to tell this is forward. This is a normal C-shaped curve. The kyphosis here, or the concavity, is posterior. This is another one of my patients not too long ago, and you can see that the curve is all messed up. Not only is it not lordotic, it's actually kyphotic. It's went backwards, and that creates all sorts of biomechanical problems. So how do you keep, or what makes a normal alignment, assuming that your bones are formed normally? Well, muscles and ligaments are the key to keeping those bones in place, those little square blocks. So you have to have properly functioning muscles, especially properly functioning ligaments. Part of the problem with degenerative change, in some cases, the ligaments wear out and they get loose, and they allow too much movement between adjacent bones, and that can wear them out. So that's important. So dysfunction of the muscles or ligaments may lead to dysfunctional biomechanics. Dysfunctional biomechanics may lead to degenerative change. It wears out the motion segment. What's a motion segment again? Just quick recap. So if we have a bone here, all right, let's just there's the spinous process. So this is a side view. Here's another bone below it. Okay. We have a disc in the middle. This is a motion segment. So it's a vertebrae or vertebra disc vertebra sandwich. So if this is C4, T4, whatever, L4, anywhere, this would be called the L4/L5 motion segment. Same in the cervical. So when I say motion segment, I'm talking about two adjacent vertebrae and the disc in between. Okay? All right. So dysfunction of muscles and ligaments can lead to screwed up biomechanics. Screwed up biomechanics wears out the motion segment and creates degenerative change, which can turn into sometimes, but not always, chronic pain. Some of the main muscles, so these are key muscles. Of course, you students studying for boards, you're going to need to know origins, insertions, nerve supply to all these muscles, the action of these muscles. I'm not going that deep into this, but some big players here are the SCM muscle, sternocleidomastoid, the upper fibers of the trapezius muscles here. Then we have the semispinalis capitis, splenius capitis muscles. These are kind of some major big players here that keep things in check. We have, what else do we have? The strap muscles in the front. You'll learn that in Gross 2 anatomy. No, Gross 1 anatomy will teach you that. Strap muscles, sternohyoid, thyrohyoid. I won't go into all those. Omohyoid. Digastric muscles, stylohyoid muscles come down from this region, connect into the hyoid bone down here. So these are the major deep muscles, some of them. Now, if you go deep, great board stuff right here. Boards absolutely love this triangle. So make sure you know that. We cut away the semispinalis capitis and splenius capitis. If you look underneath this, there's this cool little triangle right here. You got to know the muscles of the triangle. I'm talking to the medical students and chiropractic students, etc. right now. If you lay people don't need to know this, but it's good to appreciate how complicated cervical spine anatomy is. Here's the bones underneath here. So for you primary healthcare provider students, rectus capitis posterior major is part of the more medial part of the triangle. We have obliquus capitis inferior, obliquus capitis superior here. That is the so-called suboccipital triangle. Who cares about the triangle? Well, there's something inside the triangle. V2 is actually, that should be V3. Sorry about that. That's an error. Let's fix that on the video for you people who might be watching this silently. It's actually V3. And this is also V3 right here of the vertebral artery. But inside the triangle, we have V3. And we also have the dorsal ramus of C1, which actually is the nerve that supplies these muscles with life. This is also called the suboccipital nerve. All right, so ligaments are also important. So there's some familiar ligaments we've talked about in other videos. There's the anterior longitudinal ligament right here. There's the posterior longitudinal ligament. Those hold these little blocks together. There's the intervertebral disc, holds the little blocks together. When you get up higher in the cervical spine, the posterior longitudinal ligament, once you get up to C2, changes names and becomes the tectoral membrane. We'll look at that a little more closely when we get into it. But these ligaments, anterior longitudinal ligament, posterior longitudinal ligament, they go all the way down to the lumbar spine. So these are common. If we go this way, well, everybody has, these are the zygapophyseal joints or facet joints. They all have a capsule around them, so that's called the capsular ligament. But this one is super important, right? Clinically, we'll talk about this. This yellow one is called ligamentum flavum, and that is found all the way down to the lumbar spine. That holds the posterior arches together, and we'll look at what I mean by posterior arch here in a minute, or vertebral arch, I should call it. But there's only one weird place. The ligamentum flavum changes names above C1. Actually, it connects the posterior arch of C1 to the occiput. This is called the posterior atlanto-occipital membrane. Can be clinically important because it's associated with something called the posterior ponticus, and we'll look at that when the time comes. right? If we cut away the spinous process and look from a P to A view, we can see some really deep ligaments. We've removed the posterior arch, so ligamentum flavum is gone, the spinal cord is gone. We see the posterior longitudinal ligament changes in to the tectoral membrane right here. Okay, kind of looked at that from a side. If you take off the tectoral membrane, if you scrape that off, we have a really important cluster of ligaments that are super deep. So this is the cruciform ligament because it looks like a cross. And this one coming across right here, that is the transverse ligament of Atlas. That is very important for the stability of C1 and C2. Some of you who have rheumatoid arthritis who are watching this video, rheumatoid arthritis is an autoimmune attack against ligaments. And people with rheumatoid arthritis, they can get an inflammation and destruction of this ligament, and they can lose stability between C1 and C2. They get in a car accident, they can die from this because the ligament isn't there to prevent the spinal cord from being injured because of the lack of instability. So that's a super important ligament, the transverse ligament of Atlas. It has superior fibers, inferior fibers. We'll look at these more specifically in a little while, though. Ligamentum flavum, I said that's super important clinically. It's paired. There's one on each side. It connects the adjacent lamina together. So it basically stabilizes the posterior columns. We'll take a look up several pictures. We'll look at it. Specifically, it hooks the anterior inferior surface of the superior vertebrae with the posterior superior surface of the inferior vertebrae. Okay, so anterior inferior surface of the top bone, and it runs to the posterior superior surface of the inferior bone. Super important for stabilizing the spine everywhere. Lumbar, thoracic. Less important in thoracic because you have ribs, but especially important in the cervical spine. It runs from C1, the bottom inferior, C1, C2, all the way through L5, S1. It's normally about 5 millimeters thick, but it thins out in the cervical spine. Best seen if you're Ant-Man and jump inside the vertebral canal and look backwards. That's the best way to see it. So here's that view. This is an anterior to posterior view, but the vertebral body, let's change my color. So the vertebral body would be right here, be blocking our view. So the vertebral body is connected to the posterior arch by these pedicles. So if you cut the pedicles, you can pull off the anterior body and see quite nicely. We pulled out the spinal cord or the cauda equina, wherever you're talking. It's all the same in the spine. But here you can see the lamina here and here. And you can see ligamentum flavum quite nicely. We'll talk about why it's yellow. In fact, ligamentum flavum means yellow ligament. So we'll talk about it's kind of stretchy. It's springy, and we'll look at that here in a second. Here's a cadaver view of that, the same view, maybe twisted just a little bit, and you can see ligamentum flavum right here, and the lamina or the roof of the vertebral canal is right here. There's a roof. There's the pedicles cut here and here. So kind of A to P with a little obliqueness there. It goes out, so it connects not only the lamina together, but it also connects to the facet joint itself. It supports the facet joint capsule. There's 3 variations that have been described of the ligamentum flavum. Some don't actually support the capsule. Some go about halfway across the capsule, and another version goes all the way and completely covers. I'll show you a picture here in a second. They usually blend together. The right side and the left side come together. Sometimes it even intermingles with fibers from the anterior part of the interspinous ligament. But C2, ligamentum flavum, is very thin, and that's C2 is actually pierced by C2 spinal nerve. And some, Panjabi demonstrated in a study that it's not even there in some people. Okay, here's a nice picture. So this is an overhead view. Here's the spinous, and we'll get to these parts in a minute. But spinous process, here's the lamina, and here is ligamentum flavum. This is the type of ligamentum flavum that completely covers the capsule. So look, it's pretty close to the nerve run of the exudating nerve roots here, right? You don't want to compress these things, so it's clinically important here. So there it is, ligamentum flavum. So histologically, there's a yellow elastin. So the fibers of ligamentum flavum are blended with yellow elastin, which gives it a yellow look. But more important than the color, it's really contractile in nature. If you cut it out and put it on the table, it kind of shrinks and soaks together because, well, maybe I'm exaggerating a little bit there, but it pulls together is one of the important things. So it has ability to contract, and that actually can aid in extension. If you flex your neck forward, when you start to pull your neck back, it contracts and helps pull the neck very subtly, but it does. If you lose that contractibility is important to get it out of the way when you are extending the cervical spine or bending the cervical spine back, because if it contracts, it won't buckle. Degenerative changes can cause the ligamentum flavum to stop or to lose its contractile property. And therefore, when you bend back, instead of shrinking out of the way, it can bulge or buckle forward, and it can pinch the spinal cord itself. That's called stenosis. And that's not a good thing. The buckling, if in the lumbar spine, it can compress the cauda equina. This is normally accompanied by loss of disc height, which makes things worse. But if it gets bad enough, it can compress the spinal cord, and you can get something called myelopathy, which is very serious, or radiculopathy, usually more in the lumbar spine. Both of those are clinically important and cause significant pain and disability in people. Degenerative changes, everything I just said, degenerative changes cause the ligament to dry out and lose its contraction ability, and therefore if it starts to buckle by itself because it doesn't shrink anymore, it can start to irritate the posterior part of the spinal cord, cauda equina, everything I said, which results in something called central stenosis. And we'll look at an example of that in a minute. Degenerative disc disease, which decreases the height of the disc, kind of burns away the disc, that can make it worse, especially with degenerative change, because it can buckle forward and lead to stenosis as well. I have a video on stenosis that's actually very popular, so I encourage you to look at my other videos because I can't explain everything in one video. This one's long enough as it is. For reasons we don't understand, another common problem is ligamentum flavum hypertrophy. Ligamentum flavum can get really ridiculously thick in some people. And if it gets thick, it can start to narrow or pinch on the spinal cord or the cauda equina down in the lumbar spine. And that can cause pain and dysfunction because of that. Here's a good example. So here's an old client, 2016. Here's a normal overhead view. We can see the disc here. My students, especially if you went through my first core spinal anatomy course, you'll know exactly what this is. There is the thecal sac and the nerves of the cauda equina hanging out here. Everybody's happy. Superior articular process of the bone below. Inferior articular process is right here. Together, that's the facet joint or zygapophyseal joint or Z joint. In school, you'll learn it as the zygapophyseal joint. In the real world, it's the facet joint. And I've explained that before, and if you have class with me coming up, we'll talk about why. But anyway, this is normal. There's if this is looks like L4, there's the L4 traversing or exiting nerve roots. Dorsal root ganglia are here. And there's the traversing L5 roots. So everybody's happy. Ligamentum flavum, look at this. See this little black thing right here? That's a normal ligamentum flavum. It shouldn't be any thicker than that. Right? There it is. This is the type that doesn't go all the way around. Okay, now pop over to this image. So here's another client of mine a couple of years ago. He couldn't walk more than a couple blocks, and his legs felt like they were walking through cement and burned and had back pain with this. Look at ligamentum flavum in this guy. It's went crazy. Look at it. It's ridiculous. We don't know what causes this. It's like benign prostatic hyperplasia. Guys get that prostate growth, and it pinches the urethra, and you can't go to the bathroom. What causes the prostate to go? We're not 100% sure. But there it is. That's ligament. It's ridiculous. So instead of having a big and beautiful looking cauda equina, here's the cauda equina in this person, smashed up in this little ball. This is epidural fat back here, this white stuff. So that's central stenosis. That's a big problem. I talk to people all the time with this. They also had a slip here. You can see the slip of the inferior articular process. They had it's called a degenerative spondylolisthesis. I'll try not to do too many digressions because this is a long PowerPoint. What else can mess up the normal biomechanics? Well, normally the bones are like little rectangles. What if one's not rectangular in shape? That happens occasionally. It's rare, but it can happen. So sometimes you can get a triangular shaped vertebrae. That's called a hemivertebra. And that's a problem. These are just like kids' building blocks because of this one's triangular shaped, and this is an A to P view looking from the front. Or we could say we're looking at the back, a posterior anterior view. But because this is tipped, this one has to tip. So you get yourself a scoliosis wherever this occurs. If it occurs in the cervical spine, get yourself a cervical scoliosis. I got a nice video on scoliosis as well that you can look for on my YouTube channel. Again, most of my videos are pretty deep. They're not super, super simple, but most of my coaching clients, I refer to these videos because if they get up to speed on this anatomy, it helps them, and I don't have to. I can save time during the coaching session, focus on their problem rather than explaining anatomy to them. Okay, so here's a patient who was born with a hemivertebrae. So there's C4, C3, C2. They're considered kind of accessory ossicles, but that's a hemivertebrae, and it's a little triangle that has formed. Sometimes in thoracic spine you can have ribs attached to them. They can have new ribs. But that's no good, right? It completely messed up the biomechanics, and now he's starting to wear out his uncinate processes and his facet joints, and it's got chronic pain on top of this scoliosis. So here's another one on plane radiograph, very common. Difficult to see, right? But watch out for this. Always count pedicles. So pedicle, right there, the little eyes. If you don't know what I'm talking about, I have videos on how to read your lumbar MRI and how to read your cervical, or not MRI, but x-rays. So go look at those if you're kind of lost on this. But if you count pedicles, there's one here and there's one here, but we have an extra one right there. So that little triangle is almost what we showed above. That's between T1 and T2. I drew it in. If you're having trouble seeing it, I drew it in right here. And yep, that caused a scoliosis and resulted in chronic pain. So now let's dig into, I never know, should I put this part first or do I talk about the curves first or do I talk about the vertebrae first? So I just went with the curves first. But now let's get down to this vertebrae here and really look at the parts of the vertebrae. Again, there's 7 cervical vertebrae. They're stacked on top of each other. Here they are. There's C1 is called atlas. C2 is called axis. These don't have any special names. C3, C4, C5, C6, C7. Sometimes this is called the vertebral prominens because it sticks out farther than the other spinous processes. So we have typical and atypical. The typical ones, those of you who have went through my lumbar training, you'll know they're very similar in structure. So C3 through C6 are considered typical cervical vertebrae. C6 is it's still in there, but it can be a little weird sometimes. C3 through C5 have a double, like a snake tongue for a spinous process. C6 sometimes doesn't have that and has a regular straight spinous process, but it's still, according to Cramer, classified as typical. The weird ones are Atlas C1, Axis C2. These guys are strange, and we'll take a look at those in a bit. Those are classified as atypical cervical vertebrae. C7 is not typical because I won't get into all the things, but its spinous process is really long. It's never bifid. We'll never say never, but it's almost never bifid. And it's not as strange as Atlas and Axis, but it's strange. We'll look at that a little bit more. I'll tell you why it's strange in a bit. So here's the typical C3 through C6. There's typical vertebrae. Here's the ligaments. We've already looked at these. I didn't show you the back ligaments, but if you went through my lumbar series, you know this is the interspinous ligament right here. In the cervical region, we have a different ligament in back here. This is called ligamentum nuchae, or the nuchal ligament. And this is different. We don't have that in the thoracic or lumbar spine. See C7? That's the end of it right there. The other weird thing about ligaments in the cervical spine, this is the supraspinous ligament, this gray thick one here that runs on the tip of the spinous processes. We don't have that in the cervical spine. I mean, we have it, but it's considered part of ligamentum nuchae. There's 3 parts. Some authors say 2, some authors say 3. We're going to go with Cramer and Standring, which is the big, thick, that black book, that black Gray's Anatomy. So they just say 2 parts. Some authors actually include the interspinous ligament, which is right here. They include that as part of ligamentum nuchae. But so there you go. The ligamentum flavum are still the same until we get up higher. So facet joint capsules are the same. Okay, part of atypical. So let's go through these parts. I'm not going to go crazy on this, but I will list them for you. You chiropractic students and medical students and physical therapy students, you guys need to know every nook and cranny of this bone. You lay people out there, if you're going to have a coaching session with me, you better know something about this, because I'll assume that you know what the lamina is and the spinous process is, and the vertebral body is here in the middle. The uncinate processes, I'll show you a case I had not too long ago with uncinate problems with this uncinate process, these Batman ears. You got to know what those are. Those aren't seen anywhere else in the spine. The transverse processes are weird. Normally there's just one strut for a transverse process, or some authors call these bars. I think Standring calls them bars, so you probably won't see strut on board, but I like strut. So there's an anterior and a posterior strut, or anterior and posterior bar. So your transverse processes are a double strutted creature. And then there's this intertubercular lamellae, which kind of fuses them together. There's a big bump here and here. Those are called the tubercles, the anterior and posterior tubercle. They're muscle attachment sites that are important. You can see them, I labeled them over here. So kind of a weird design. There's another hole in the transverse. We don't have holes in the transverse. You've never seen this before in the lumbar spine. But here we have vertebral arteries will pass through here on each side. So these are really important. All right, there's this facet of the supraarticular process. Articular pillar, we'll look at that from the side. Did I get everything? It has a pedicle as well. So the pedicle is kind of part of the strut. The posterior strut here kind of morphs, kind of blends in with a pedicle, but it's still a very hard piece of bone. Lamina, bifid spinous process. See how it's got 2 little fins here to match the 2 little struts of the transverse process. Okay, so it's good to know this stuff. And you healthcare provider students, you got to know that stuff. Here's a side view, sagittal view. I talk about the articular pillar a lot. In the side view, we can see this is the articular pillar. I put it in pink here, or purple, or I don't know what color that is. But there it is. So if you draw a line right about here, that's kind of the halfway point between the articular pillar. Anything above this, I can draw it, right? I got my tools out here for you. So right about here is the midway point. Anything above this, superior articular process. Anything below this, inferior articular process. We can see a little pad right here. There's in the living, there's a pad of hyaline cartilage here, and that's articular cartilage. So that's called the facet of the inferior articular process, or you could call it the inferior articular, or you could call it the facet of the inferior articular process, or you could call it inferior articular facet, I guess, too. The other one is hidden on the back side. It would be over here, but those are facets. Those are your Z joints. Those are your facet joints. Okay, we can see the struts of the transverse processes coming out of the plane of the page here and here. We can see this weird looking thing, because I mean here the vertebral body's kind of rectangular, right? What in the heck is that? That's called an uncinate process. So it forms a joint And we'll look at that here in a second. I don't want to get too far ahead. All right, there's the spinous process. Everybody, you lay people who don't know this, everybody put your hand, your fingers of your right hand, it doesn't matter what hand, put your fingers right on the back of your head, right in the center where that little bump is on the hair in the back of your head. Now run your fingers down your neck, and as you come to where your neck attaches to your trunk, you're going to feel some big bumps. What are you feeling? Spinous process, this thing right here. Those are the things that stick out. Right, here's a nice oblique view, very busy. We can see the vertebral body in the front. There's our transverse process. There's our transverse foramen we talked about. There's our articular pillar from this view. Spinous process. There's our lamina, a vertebral end plate. Here's a nice view of these Batman ears, articular processes that pop up. They're part of a joint called the Uncovertebral joint. I got slides coming here. This is important right here as well. There's a notch here, and that's because it's on the superior part of the vertebrae. That's called the superior vertebral notch. That makes up the bottom half of this hole, which transmits the spinal nerves. So this is a very important thing, but notice that the uncinate process and the superior articular process, they make up the borders of this hole. Well, guess what happens if you get arthritic change? What if you get a bone spur that grows like this? It can shish kebab the nerve right there, and you can have pain going down your upper extremity from this type of arthritic change. We'll look at that a little more. This is important down here, too. That is the facet for the uncinate process. The facet for the uncinate process. This would connect to Batman's ears up here. Now we can't see the one below, but the one below would be connecting right. If I could draw it right through, it would be connecting to it like this underneath. So these two together, the uncinate process and the facet for the uncinate process, make up a new joint, which is semi-diarthroidal. Don't have those anywhere else in the spine, only in the cervical spine. It's got a capsule around it. It's got some synovial fluid. A little controversial if it's a true diarthroidal joint or not. But yeah, so I think I covered all that stuff there. Uncovertebral joints. So super important concept to cervical spine patients, especially with arthritis. They're also called the Luschka joints, or the joints of von Luschka, after the guy who discovered it, or the uncovertebral joints of von Luschka. Uncovertebral joints is what I usually call them, or sometimes I just call them Luschka joints. Only in the cervical spine, and they're not everywhere in the cervical spine. C1 and C2 atlas and axis don't have them. They're the most prominent at C4, 5, and 6. They are made by two pieces, the uncinate process. Sometimes that's called the uncus, and that connects with the facet for the uncinate process, which we just talked about. They look like Batman's ears. All right, and there's the two parts again. The uncinate process, I already said this, uncus, and you can read through this because I just talked about that. All right, and it's kind of a semi-diarthroidal joint because it does have synovial cells, and there is some synovial slipperiness, but it doesn't usually have a complete full capsule. So it's similar to the SI joint, sacroiliac joint. Sacroiliac joint is more diarthroidal, but it doesn't have a posterior capsule, so it's kind of in the categories with that. If you don't know what Batman ears are, there is Batman. See, don't they look like Batman's ears? Who are those guys? Those are the uncinate processes, or the uncus. And there they are. I guess I should have got the camera down a little lower, but you can see the ridge of these things right here. Alrighty, let's go. So clinically super important. They provide lateral stability to the cervical spine. There's no ribs. So we need something to stabilize the spine, and that's why the committee developed these things. They make up the anterior and anterolateral border of the neuroforamen, which I showed you. I demonstrated a spur, bone spur, which stabbed which compressed or decreased the size of a neuroforamen. Neuroforamen is the hole. We'll look at those a little more specifically in a minute, but that's the hole where the spinal nerves leave the spine through. So they can cause radiculopathy, radicular pain. They're also close to the vertebral artery, so sometimes, doesn't happen that often, but you can get your vertebral artery compressed by uncus spurring or uncinate process spurring. All right, so here's a cartoon. I kind of drew this already for you, but here's a normal spinal nerve where it comes out of, this is just half of the neuroforamen or intervertebral foramen, as AKA or IVF. But you can see this nerve coming out, splits into anterior and posterior ramus. Everybody's happy. There's the uncinate process. Everybody looks good there. There's superior articular process. Nobody bothering that nerve. But in this patient, they developed arthritis of the joints of von Luschka, or specifically of the uncinate process in this cartoon. And it crunched the nerve, and now the nerve is all inflamed because of the irritation, and the patient has pain going down the arm, and maybe some, depending on what nerve it is, maybe some biceps power loss or grip strength loss and burning pain and all sorts of radicular pain and radiculopathy, even if there's positive neurological findings. Okay, look at this case. This is a case I just recently had. So this is, now I'm just going to modify this a little bit because it's a little more complicated than this, but basically, let's look at from an A to P view. This is a CT scan. You can see Batman's ears really nice here. Can you see him sticking up? Right, that looks like Batman. There's uncinate processes here. That one looks okay. These look okay, but look what in the world has happened here. So we have really bad bone spur formation coming out. The neuroforamen, of course, goes right through this region here. And the nerve runs right through here. Right? So it's really in close proximity to this thing. So this is no good. Here's the cut line. Those of you who've looked at my How to Read Your Lumbar MRI video know exactly what this is. But it shows an overhead view, really from the bottom up view. That's why the sides are reversed. But here's the uncinate process on this side. So that would be right here. You can see the cut going through it. And then there's a black space. There's the black space from the cut here. Then it goes back to bone. And then bone, bone, bone. And then what in the world has happened here? So that's all degenerative change. And look at the size. Here's the neuroforamen here. Right? It's huge. It's massive. The nerve would go right through here. Right? No problem here. What about the nerve trying to get through here? It can't. It's smashed. Right? It's smashed, and now it's all red and inflamed. Yeah, no good. Okay, so these little Batman ears are really important in some patients. Holes of the spine, let's check those out. We talked about them a little bit. Let's really nail those down. So there's two important protective holes. Super important. We have the vertebral foramen, which is that hole in the center. Collectively, if you have a motion segment, you have two vertebral foramen make up the vertebral canal. Vertebral canal runs from the foramen magnum all the way down through your cervical spine, all the way down thoracic, lumbar, sacrum. So vertebral canal is important. And then the neuroforamen are how the spinal nerve roots get out of the spine, which we'll look at as we go. Let's start with the neuroforamen, also called, chiropractors tend to call these intervertebral foramen. Medical docs tend to call them neuroforamen. Also an AKA for intervertebral foramen is IVF, not in vitro fertilization. That's part of the reason I prefer neuroforamen. Anyway, they're all AKAs. They're created by these vertebral notches, which I showed you a superior vertebral notch. But there's an inferior vertebral notch. Together, they come together and form a hole. And what comes out of the hole? Spinal nerve roots come out of the hole. Usually the spinal nerve itself, and we'll get this technology, these divisions of the spinal nerve roots are tricky, and we'll look at that here in a second. You got some arteries and veins that run through there as well. Naming, this is, see, I put a star here, very for all boards and for you patients or you lay people as well. You got to understand what nerve comes out of what hole. So the hole, first of all, how do you name the hole? That's named by the two vertebral notches that create it. It's as simple as that. If the C5, the inferior, well, I'll just show you. We'll show you here in a second. The nerve root is the tricky one. So the nerve root is named by the superior vertebral notch, names the nerve root. In other words, the inferior member of the motion segment names it. So if you have a L4, L5, or a C4, C5 motion segment, what nerve comes out between C4 and C5? C5 does. In the lumbar spine, what nerve comes out between L4 and L5? L4 does. See, same with the thoracic spine. So there's a difference here. Anytime there's weirdness, boards, no matter what boards, they like to test on that stuff. So make sure you're familiar with that. If you're trying to read the radiology report, you need to know that too. So this is important for everybody to understand. Let's look at an example. It's probably the best way. To see the neuroforamen of the cervical spine, we don't look straight laterally or from a sagittal view like we do with the lumbar and thoracic. We actually have to look obliquely anteriorly. We have to do an oblique type view. So this is an A to P view, but it's twisted a little bit laterally, and therefore it makes the whole. I could have actually rotated the skeleton a little further for you. But nevertheless, we can see the neuroforamen right here. How are these neuroforamen named? C2 and C3, this is the C2/3 neuroforamen. Some docs will just say that's the C2 foramen. The bone above always names it, and that's true all the way down the spine. But the nerves is where the problem comes in. There's 7 cervical vertebrae. There's actually 8 cervical spinal nerves. That's why everything is kind of yanked up one. There's 2. C1 comes out here. C2 comes out here. And that means C3 comes out here. C4 comes out here. C5 comes out here. See how I'm naming them? Who is this then? Well, C5, C6 motion segment. The C6 spinal nerve is actually right here. It comes out of that hole. Everybody good with that? All right. Here's a view, lateral view. And you first quarter students who might be looking at this is a good way I test right here. I could put a picture on your test and draw this right here and say, what nerve is this? All I'll give you is C5 vertebral body. This is the C5 vertebrae. What nerve is that? That's the C6 exiting nerve root. Okay. So what if I give you this picture? I give you the C6 vertebrae, but I only give you the superior vertebral notch. And I ask what nerve comes out of that. Or maybe I'll be nice and draw kind of Photoshop in a nerve like I did here. Well, the nerve is named by the inferior member of the motion segment. C5 is not shown. It would be up here. C6 is here. C5 disc would be here, right? That's another important concept. I mean, we have a disc hanging out right here, right? Intervertebral disc. Can't probably see it that good here. So that would be the C5 disc. The disc is named by the bone that sits on top of it. So that's the C5 bone, right? So that's the C6 nerve. A disc herniation can pinch the C6 nerve. It can't pinch the C5 nerve. It's not like the lumbar spine. You can't get lateral herniations here because of this wall, this uncinate process. Everybody good? All right, everything I said about obliquely forward, don't have to repeat that again. So what nerve root is this? Somebody get it. Good. C6 nerve root. C6 exiting root. C6 spinal nerve. C6 spinal nerve roots here. Right? Why is it C6? That's the what? Okay, what? Let's do another quiz. What hole is this? Good. You can just name it C3, C4 neuroforamen, or you could call it the C3 neuroforamen if you want. What disc is this? Whoever sits on top of the disc conquers it. So C3 is sitting on top of it. That's the C3 disc. We good? All right, we got to talk about a little basic neural anatomy here. I'm not going to go crazy into this, but you got to know a little bit about the spinal cord. So the central nervous system, there's a peripheral nervous system and a central nervous system. The CNS, or central nervous system, is made up by two parts, the brain and the spinal cord. Spinal cord has 5 parts that match the vertebral regions. We have cervical vertebrae, we have a cervical spinal cord. We have thoracic vertebrae, we have a thoracic spinal cord. We have lumbar vertebrae, we have a lumbar spinal cord. We have sacral vertebrae, we have a sacral part of the spinal cord. And we have a coccyx, we have one coccygeal nerve as well. The weird thing about this, though, well, how many are there? That's always a good question. I'm not big with numbers, medical students and chiropractic students, etc. 31 spinal nerves you need to know. And there's 8 of them here, which is the weird one. There's only 7 bones, but there's 8 vertebrae, or 8 spinal nerves. All right, once again, the spinal cord and spinal nerves are protected. So I'm just showing you. So the spinal cord is protected by the vertebral canal. That's the vertebral canal. The spinal nerves, as they leave the spine, are protected by the neuroforamen, aka intervertebral foramen. Some fun facts. There's your 31 pairs of spinal nerves. Here's the weird thing, though. Notice the spinal cord stops right here about the level of L2, between L1 and L2, usually the L1 disc, and normally. Very strange, right? During development, it just gets left behind. So we have a different setup. The nerves and tracts are embedded in the spinal cord in a solid substance. And you'll learn about that in neural anatomy. I'm not going into that. But what about down here? I mean, you still have organs in your pelvis and your legs. How does that work? Well, these nerves just hang in a sac. I mean, you have I don't think I said this, but the foramen magnum is the hole that comes out of the skull. Foramen magnum is here. You have a sac that goes all the way down here to S2. Okay, that's called the thecal sac. Thecal sac. I don't want to do too much drawing because my finger drawing is not great. Thecal sac, or it's also called the dural sac. This is filled with cerebral spinal fluids and bathes and gives nutrients to all this neural tissue. It's super important. But the weird point is, and the part it's hard for students to understand, the spinal cord is done here. So up here, let's go up here. So let's say let's do with your 8th cervical nerve right here. So that your 8th cervical nerve is going to come out of the C7 neuroforamen, and the cord level itself, where the nerves go into and out of the cord, is right at the same level. But L5, we'll use L5, the L5 spinal cord level is way up here. It's about right here, about at the level of L1. So that's the spinal cord level, but it just has these super long nerve roots. So the IVF for it, the hole where the nerve comes out, is way down here between L5 and S1. So that's a weird setup with the spinal cord. Why the committee didn't make this longer is beyond me. No one knows for sure. Okay, this end region is called the conus medullaris, down where the sacral and coccygeal spinal cord levels are. Conus medullaris. All right, now we got to conquer this spinal nerve thing and spinal nerve root, dorsal root ganglia. What is the difference between all this stuff? So at every spinal cord level, no matter, even if it's L5, the spinal cord has a region where nerves enter it, and that's called the spinal cord level. This would be the C6 level. This would be the C5 level that is unsheathed. We have dura mater, which is, we have three meninges, the dura mater, the arachnoid mater, stuck together. And the pia mater is actually around that white thing right there is pia mater. But at each cord level, we have these, it looks like a tree, right? These looks like roots coming out of the ground. The ground would be the spinal cord. These are called the nerve rootlets. And they give rise to a spinal nerve root or spinal nerve root. Sometimes they're just called, this is the nerve root, right? So same thing here. Now we have two types of these things. Where you see this little bump right here, that gives away that these are all sensory nerves here. We also know because this is the dorsal region, the back, and this is the anterior region in the front. So these are where your sensory nerves are headed into the spinal cord and will go up to the brain. But and they enter the spinal cord. I won't go into further than that. These guys are all motor nerves. They're coming out of the brain. They're commands. The brain made a command, and it's going to, let's say, to twitch move your index finger. It's headed that way. So these rootlets convert into roots. The nerve roots merge again after this bump, which is called the dorsal root ganglia. This is where the nerve cell bodies of all your sensory nerves live. It's really important, really delicate. Not good to get a herniation touching that thing. But notice how these spinal nerve roots come together, the motor and sensory come together right after the dorsal root ganglion, right about here. That is your official spinal nerve. Okay, people use that term to talk about the nerve rootlets. They'll say spinal nerve. To talk about the spinal nerve root, they'll say, or they just mix all these terms together. They shouldn't really do that. These are the nerve rootlets. These are the spinal nerve roots, sometimes just called the root or the motor root, sensory root. That means that these little rootlets have come together. Where they both merge, that is the official spinal nerve. What's the board question about a spinal nerve? Probably on every board there ever is. This is a mixed nerve. We got incoming signals, sensory signals. Let's say you touched something with your finger, it was hot, the message is going to the brain. We got outgoing messages. So it's called a mixed nerve, the spinal nerve is. Are we good with that? We also have some gray ramus communicons coming in here. We're not going to talk about those in this video, but it's a little more, there's some sympathetic flow coming in here as well, but we're not going to talk about that in this video. Okay, everybody good with that? So we know what nerve roots are. We know what these spinal nerve roots are, or just dorsal motor roots are. We know what the dorsal root ganglia. We know that this is the spinal nerve. Where's the intervertebral foramen? The intervertebral foramen is usually right here, because the dorsal root ganglion usually lives in the intervertebral foramen or neuroforamen. And the first thing that pops out, that's the spinal nerve. Are we good? Okay, play it back. This is very important stuff. All right, and we let's see. Everything I just said is kind of laid out for you. So there we have a sensory root. You could call it a sensory spinal root as well, or a sensory spinal nerve. You can say spinal nerve, but say something in front of it. Sensory spinal nerve, or you could say afferent spinal nerve. Same as sensory. Afferent means the signals are going in. Spinal nerve is already out, and it's a mixed nerve. These guys are not mixed nerves. These only have incoming signals. This motor root only has outgoing signals. Are we good? Do we understand that? Awesome. Okay, kind of a gross for some of you, but this is a overhead view of a slice through the C6 level. The front would be up here. The back would be back here. Okay, this is C6. Therefore, this is the C6 spinal cord itself. You can see the gray mater, the H shape in the middle. I won't get into that. And the white mater around the outside. I'm sorry, matter. There's a difference between mater, dura mater. That's the protection. We can actually see dura mater would be right here around the outside. Let me change that color. Dura mater's here. Arachnoid would be stuck to the inside of the dura mater. Those two are really tough, stuck together. This is all the subdural space here, or the epidural space, or the interdural space or interthecal space. Epidural space would be out in this region. There's epidural space here. Okay, and there's our roots, right? There's our ventral root, C6. There's our dorsal root, or motor root. Or I'm sorry, that's our ventral motor root. There's our dorsal sensory root back here. Dorsal root ganglion, we can't really see. They left the fat. See, that's all packed. There's the intervertebral foramen, all packed with fat there. Here's our Z joint, though. Here's our facet joint right here. You can see this one better, right? Who makes the zygapophyseal joint? This is the superior articular process. So this is the inferior articular process. This is all lamina right here. This is lamina as well. All right. Awesome. And again, another for you primary healthcare students, got to know this picture. It's good for my coaching clients to know this as well. So here we go. So this is the disc would be right in here. So let's look at some of these parts. There's the spinal cord again. We have the H-shaped gray matter here. That's the white matter, all the myelinated tracts. Remember I said there's no nerve roots. They're all embedded in this stuff. So this is the C6 level. So these are all C6 nerve rootlets here. Okay. These are in the front. So these are the motor. They're headed this way. These are the back. So the signal's going that way. Okay. Awesome. So now this would be the sensory nerve root, number 18. See, the nerve rootlets have come together to form the sensory nerve root. And if you keep going, there is the dorsal root ganglia. Okay, great. We have dura mater is in light gray. Arachnoid mater is in maybe a darker gray. And you can follow those and see that the dura mater and the arachnoid mater actually follow the spinal nerve out. And they morph into the nerve root coverings that you've learned. The epineurium and there's an endoneurium, what you can't see. The perineurium would arise from the arachnoid layer. The epineurium would arise probably right about here. Those would morph into those tissues. I won't get into that any more than that. But yeah, so everything we've just talked about. But now let's go a little further. Here is the spinal nerve, which is a mixed nerve. Everything's mixed up from now on. But the spinal nerve is very short-lived. It splits into two pieces very quickly. This big, thick piece is called the ventral or the anterior ramus. So that's the anterior ramus. This split is the posterior ramus. Some call them anterior primary ramus. I go with Gray's Anatomy, but there's a little controversy on what to call these, so be careful. Check with your teacher to see what they're calling them. I'm calling them like Gray's Anatomy and like Snell's Neural Anatomy. I really like Snell. They both call these just simply the anterior rami, posterior rami. Posterior rami are important. That's going to split into two branches. A medial branch, so that's the medial branch of the posterior rami. That one's going to give life to the facet joint here. People with chronic facet joint pain, the pain is transmitted down the medial branch. There's medial branch blocks that you've probably heard me talk about. There's a lateral ramus right here. Oh, by the way, this goes up a branch. I didn't draw it, but this goes out and supplies the multifida muscle above. That's just a little patch of the multifida muscle. This is the lateral branch here. Some people have an intermediate branch as well, which I didn't draw in here. Okay, we have a gray ramus communicantes coming in. There's the sympathetic chain. I'm not going to go down that road. I'll let your gross anatomy teachers talk to you about that. But this is a brachial plexus, right? If this is C6, this is going to be the second root of the brachial plexus that you guys are going to study. Right, I think we got everything. Everybody good with that? Super important slide. Just another important slide you can look at while I take a sip of water. Sorry, I'm not going to have time to edit this out of here. Okay, it shows the vertebral arteries quite nicely. Notice there's 2, sometimes 3 vertebral veins that run along with those. This is the epidural venous plexus. This is also called the epidural space. Okay, when you go to the doctor, you have sciatica or radicular pain, they can do an epidural. This is the epidural space that they're talking about right here. This is the interthecal space, or interdural space. There's the dura mater right here. They don't really show the arachnoid mater stuck to this. Pia mater would be right here surrounding the spinal cord and the nerve roots themselves. Notice that if this is the C5 bone, this is the C6 disc. Uncinate process is sticking up here. I think that's about all we need to say there. Vertebral foramen, vertebral canal, we're still talking about those. I just wanted to throw this slide in here too. I didn't really say. How is a vertebrae? I mean, this could have been the first slide of the whole series. A vertebrae is formed by 2 parts. There's a vertebral body and there's a vertebral arch. So we need to talk about this vertebral arch. The vertebral canal is inside the vertebral arch. Let's look at it. Vertebral arch is this. So it's the pedicle. The articular pillar is this thing. The lamina. Some authors include the root of the spinous process, and then the structures repeat on that side. The vertebral arch is not the transverse processes. It is not the spinous processes. Good with that? Okay, simple as that. Everything I just said, the parts. But the vertebral canal here, sometimes you'll hear radiologists or neurosurgeons or orthopedic spine surgeons, they'll talk about the roof. Oh, I'm going to free up the roof of the lamina. I'm going to do a laminoplasty and break open the roof of the neuroforamen or vertebral foramen. What is the roof of the vertebral foramen? They just mean this thing. They mean the lamina spinous process and other lamina. That's called the roof right here. Okay, not the articular pillar, not the pedicle here, but just the lamina spinous process. The floor of the vertebral foramen is the vertebral body back here and the disc, which we can't see, that forms the floor. Good with that? All right, now we're going to get into some crazy stuff. I might even stop the video right now and take a break and come back for atlas and axis. All right, atlas and axis, here we go, some strange bones. So very unique to the cervical spine. C1, C2 are called atlas and axis. Top 2 bones. One thing right off the bat that is weird, they don't have any of the Batman ears. They have no Luschka joints. So let's take a look at atlas first. It's Atlas, of course, held up the world, Greek mythology. That's where it got its name. So it supports the skull. It connects the skull, specifically the region of the skull it connects to is called the occiput or the occipital region. It has no vertebral body. That's right, no vertebral body. It has no uncinate processes. It has a posterior and anterior arch, which is different. We've seen a vertebral arch. Really, the posterior arch is just the vertebral arch, but we call it posterior to keep it separate. Off the posterior and anterior arch, there's little bumps for attachments of ligaments and such. Those are called the anterior and posterior tubercles. Just a side note about chiropractors and old school chiropractic belief philosophies. This is the most powerful bone, according to them. They manipulate and micro-manipulate this bone and treat all sorts of diseases with this bone. So not a whole heck of a lot of good research behind that philosophy, I could add. But nevertheless, it's been around for over 100 years, so there might be something to it that we just can't explain. So just a little side note there. The atlas provides a platform for which the skull attaches, and then together the skull and the atlas can rotate around the axis. All right, here's all the parts. So now for you lay people, unless you've had a fracture, we're going to be talking about a fracture, or you've had some upper cervical problems, you probably don't have to worry about all these parts, but you primary healthcare docs or student docs, you need to know all these nooks and crannies. So we have an anterior arch here, which we don't have anywhere else in the spine. It's the only place that has an anterior arch. It's got a bump coming off the front. That's called the anterior tubercle. It's got a transverse process just like everything else. It still has a foramen transversarium, a.k.a. transverse foramens. Watch those backwards Latin flavored a.k.a.s for those. There's the facet of the superior articular process. Really, I don't think in a bone there's really a facet there. I think that cartilage has probably been washed away, but nevertheless, you could call it that. In fact, for my Gross 1 spinal anatomy class, that's what you will call it. It is a member of the atlanto-occipital joint. The lateral mass of atlas, we'll see better from the A to P view, is right here. Okay, there's the posterior arch of atlas. There's the posterior tubercle of atlas. We'll talk about this weird thing. There's bone growth right there. What in the heck is that? Don't see it on this side, do you? No, but there's a groove for the part 3 of the vertebral artery that passes through here, and vein, and a nerve that passes through there. But this weird thing here, that's called the posterior ponticle, and we'll look at that pretty quick. If we do an anterior A to P view of the atlas, here's what we have. There's our anterior arch right here, our tubercle. There's no body. Instead of a body, we have these 2 blocks of bones, which are really nothing more than articular pillars. But these are called lateral mass, the lateral mass of atlas. That's a special name given to them. We still have a superior articular process, inferior articular process underneath, which you can't see. There's transverse foramen out here. Posterior arch is back here. The neuroforamen would be right here. That's part of the neural canal, or the vertebral canal. Vertebral foramen, did I say neural? Must be getting tired. I should have taken a break like I said it was. But this is the vertebral canal. The atlanto-occipital and atlanto-axial joints. When naming these joints, atlas is always named first out of respect, and atlas, the name for it is atlanto. So the connection between the occiput and atlas is the atlanto-occipital joint. No rotation, no significant rotation occurs there. The connection between atlas and axis is called the atlanto-axial joint. That's where all the rotation of the head occurs, at that joint. They're both true diarthrodial joints. They have a capsule, they have articular cartilage, they have synovial tissue in there, they secrete filled with synovial fluid, just like the joint of your knee. They're a true diarthrodial joint. If we cut the back off, so this is the PA view, and we've cut the posterior arch of atlas off, and we've cut the lamina off of C2 as well, right here, so we can see what's going on. And we've stripped away some ligaments. We actually see the cruciform ligaments. We'll talk about those more in a minute. There's the facet joint capsules. If you take off the facet joint capsules, you got the atlanto-axial joints, atlanto-occipital joints right there. This is where the rotation occurs, right there. Here's a CT. CT is cool because you can put a slice right through whatever you want to look at. Here's a slice right through C2. There's the dens we'll look at. There's the lateral mass of atlas. Right, lateral mass of atlas. There's the occipital condyles. But there's the atlanto-occipital joint and the atlanto-axial joint. It's right there. Okay, these are real bone specimens. And, yep, there they are. There's atlas, transverse process, transverse foramen. There's that groove for the vertebral artery here. Posterior tubercle, posterior arch. And there's that weird thing again. What the heck is that? You don't see it here. What is that? I'll tell you what that is. That's the posterior, what is that? That is the posterior atlanto-occipital membrane. For whatever reason, it likes to calcify in this region and kind of morph into the posterior arch. So that's called the posterior ponticle. And it creates a new hole. We don't have a hole here. We have a hole here. That's called the foramen, the arcuate foramen. That's called. I think I have slides on that. So another important thing, though, so we're looking at atlas sitting on axis. Spinal cord, right? Spinal cord would be, that super delicate spinal cord would be coming right through this hole here, right? Very delicate, can't stand any compression. So what's to stop this bone from sliding forward and this, let's change colors, this from jamming into the spinal cord and paralyzing you? That's a problem, right? Well, luckily we have a super strong ligament called the transverse ligament of atlas. Connects to these bumps right here, collicula atlantos, the name for those bumps. And it lassos the back of this. Therefore, if you push this forward, this will not let it go forward. It'll stop it. It's a very strong ligament. And there's another ligament over the top. Remember, the transverse ligament atlas is just part of the cruciform ligament. Good? What else did I want to show you? Oh, let's talk about the vertebral artery. Now, you guys don't, you lay people don't need to know this, but V2 is coming from, there's transverse foramen of C3. Right when the artery comes out of C2, it changes names. It's called V3 of this part, V3 of the vertebral artery. It does a little kink here. It goes up through the transverse foramen of 1, and it does this wicked bend. See how it bends like that to go in the groove underneath here for the vertebral artery? And then it rips through dura mater and becomes V4, and then it goes up here to go to the base, or it goes up higher, but it goes up here, and then it hooks up with the, forms what's called the basilar artery from the other side coming across. So yeah, that's the vertebral artery. So the thing with chiropractors and strokes, a lot of times the problem happens right here. Most of those, or a lot of those patients, I don't know what the prevalence is, but if you have atherosclerotic plaque built up, if you have high cholesterol and you have plaque built up in here, and you get a chiropractic manipulation, you could break that plaque loose and send it up river here, right? Or send it downstream, and it can go up in the brain and cause a stroke. It's not just chiropractic manipulation, though. Osteopath manipulation. People who work overhead, putting in a ceiling fan, people painting on the ceiling, electricians, all are at risk. Any type of extension, rotation, lateral flexion of the spine can break these little bombs loose, and it doesn't happen, pretty darn rare, right? Chiropractic is pretty darn safe, but there are problems with it. Don't get me started too much on this. And they should, chiropractors, in fact, by law, I know in California, you have to explain this risk of stroke to patients having a chiropractic manipulation. It's pretty darn small, but nevertheless, it is there. So, sorry, digressing. All right, there's that ligament I just drew, transverse ligament of atlas. All right, let's look at axis. This is the second cervical vertebrae. Connects with C3 normally. It's got two normal zygapophyseal joints come together and connect. The top is weird, though. The top one is flat, looks like a helicopter landing pad. That's part of the atlantoaxial joint, so it is a little weird. And it's super weird because it has this weird pole coming out of it we've looked at already. That's called the DENS, or the odontoid process. You guys got to memorize that, especially if I'm consulting with you and you've had a DENS, odontoid fracture, or Jefferson fracture or something. And you should know this anatomy if you have problems up high. But the axis is where the rotation occurs. I always put that on my test, and it's always surprised how many students get that wrong. The rotation of the head is not caused by axis. The actual rotation occurs between axis and atlas, as we've said before, between the atlantoaxial joint. It's not, the rotation doesn't occur between the atlanto-occipital joint. Okay, there's a back view of that weird pole. It's pretty strange. Embryologically speaking, this was supposed to be the body of Atlas. It kind of stole it from it. I guess you can kind of think there's a little more to it than that, but You kind of think of it as that. It does have a very thick vertebral body, has nice thick pedicles here, has a lamina, bifid spinous process, transverse processes here. And then it's got these helicopter landing pads, right, superior articular facets. And then the dens has a gigantic, see that? See this big circle here? That's a pad of articular cartilage. There's a real kind of a synovial joint right here. Yeah, synovial joint. And that's for that, the transverse ligament of Atlas. Remember how that came across it like that to hold it in place. Good. All right, let's go through these ligaments. We looked at these already. So here's the normal ligaments of the spine we've already talked about in other videos. There are some different ones. So we've already talked about a little bit how C1 and C2, they have to be held firmly together. So you don't want any forward slip, no AP sagittal translation you don't want. You'll be paralyzed if that happens, if a huge amount of it happens. You don't want side-to-side slip or lateral slip. That's called horizontal translation. Look at my biomechanical spine video if you don't understand that. And let's look at the players here. We kind of looked at this. Now, I took ligamentum nuchae would be right here in the middle. I got rid of that one so we could see a little bit better. So ligamentum flavum stops between C1 and C2. And then instead of, this really is ligamentum flavum. It's quite thin. It's quite broad now. So they gave it a new name. They're calling it the posterior atlanto-occipital membrane. Right? You can still see the facet capsule. But notice this ligament, the V3, as I drew before, it actually pierces a hole through there so it can jump into its groove for the vertebral artery in here. Right? So remember, this calcifies in some people as a posterior ponticle. I think we'll look at that in a minute. Oh, here it is right here. Ossification of the posterior atlanto-occipital membrane. Yeah, so as I've already explained, you can get a new hole by that calcifying. That's called the arcuate foramen. And that sheet of bone over the top is called the posterior ponticle. It's very common. In some, on average, it's 33% of all humans have one of these at least. You can have them on both sides or on one side. Who cares about it? It's usually considered asymptomatic, just kind of an incidental finding. There's no contraindication with manipulation these days. However, there is a little bit of research out there that because V3 of the vertebral foramen pierces it, there has been some research that people with migraine headaches, especially the type of migraine headache that has an aura that comes on before it, they're at risk, or they tend to have a posterior ponticle. And then there's some scattered research about the increased risk of stroke because you got not much wiggle room for that artery, right, if it's encased in bone via the arcuate foramen. So that's pretty much been disproven, but yet, just get if you have those things bilaterally. Personally, myself, I wouldn't let anybody do cervical manipulation to myself. I'm super conservative with that. That's just my opinion. So here is the bone turning to bone. There's the posterior atlanto-occipital membrane, and for whatever weird reason, this turned to bone and formed a nice posterior ponticle there, and created an arcuate foramen. Now is the tunnel, which we can't see. Okay, we good with that? We've talked about that. There that is again. So on an X-ray, if you have them bilaterally, they're very easy to see. So here's a lateral sagittal X-ray radiograph. The dens would be right there. It's kind of hard to see. There's the anterior tubercle of Atlas right there. I have an X-ray, how to read X-ray of the cervical spine. You should check that out if you need that. And then we have the posterior ponticle right there. And that would be the, students, arcuate foramen. Great. You can't see any of the ligaments, right? X-ray and CT burn right through those ligaments. All right. Now, if we scrape all that stuff away and go into the middle layer, we can see the spinal cord's been removed. We can see the posterior longitudinal ligament. I think we covered this already. There's the tectoral membrane, goes all the way up to the foramen magnum here. just an extension of the posterior longitudinal ligament. We've already talked about these, the cruciform ligaments, how important they are. I even drew transverse ligament for you. But there it is. The transverse ligament of atlas is a member of the cruciform ligaments. Cruciform ligaments include some superior longitudinal fibers or band that runs up to the clivus past the foramen magnum. And we have some inferior fibers as well that run down. We have some other stabilizing ligaments here. Those are part of the tectoral membrane. They're a thickening and deep part of it. They're given its own name, accessory atlantoaxial ligament, it's called. And the alar ligaments, I'm not going to go any further. If we remove the cruciform ligaments, there's an apical ligament that hides right behind this. And then we have two alar ligaments that go from the tip of the dens and anchor into the foramen magnum here. So more stabilization. But of all these ligaments, the main one is the transverse ligament of atlas. All right, now we got to talk about the cervical intervertebral disc, right? Because a lot of people that I consult with, they have disc herniations. So what do we know about the cervical intervertebral disc? Well, it's very similar to the other discs, the lumbar discs. I have tons of videos on those. Talked a lot about that before. But they can succumb to those same pathological conditions as the lumbar can. Right? So they're a little bit tougher, some research shows. When a disc herniation occurs, it tends to not reabsorb by the body well because it has more annulus fibrosis in it than anything else. But let's look, if you don't know, let's tell you what the disc. Here's a generic disc, but this holds for the cervical as well. It's got a nucleus pulposus in the center, and it's corralled by these belts of collagens. Like patients or lay people, I say it's like a steel-belted radial tire. You have air in the center, but it's not air. It's like a toothpaste consistency. And that air has to be held in place so it doesn't escape. And there's the steel-belted radial. You got, 14, 16 belts of these steel belts. But they're not steel. They're made up of type 1 collagen, which is really quite strange. It's also, the design is really, the committee did a great job in a way designing this thing. But I'll show you some problems with the design too. If you drop a line straight down, a vertical line, let's drop it right down here, and then you measure these, each one of these black things is a belt, there's a sheet of type 1 collagen. So there's many sheets in each lamellae. They run negative 65 degrees from vertical. The next layer, which I can't show you here, but if I scrape this away, like this, I can show you right here. So negative 65 degrees. The next layer deep to that runs positive 65 degrees. So it's a great, strong design to keep this nucleus from squeezing out. But we got a problem with it. The nucleus is 80% water. The cells make proteoglycans, which absorb water like crazy. I've talked about that in other videos. Here's kind of cool image showing if you could pull these sheets. These sheets are called lamellae. So there's actually 15 on average belts of type 1 collagen called lamellae with their fibers running 60 degrees from vertical, and they alternate. But here's the committee problem, and we don't know why this is, but research has shown most disc herniations occur back in these posterior lateral corners, right by the nerve roots, so people get pain down their arm or leg, depending where it happens. These lamellae are incomplete there. They don't completely encircle the disc. In the front, they completely encircle the disc. Therefore, you don't see that many anterior disc herniations or lateral disc herniations. But in these back corners, they kind of peter out. And that's not good. Like right in these corners, they don't come together like they're supposed to. And that leaves a weak spot. This nuclear material can squirt out and through those and create a tear through there. Right, so that's not a good thing. The other thing, the research shows that they're actually thicker in the front and thinner in the back. So that's not a good thing. We want to protect the nerve roots would be hanging out. Let's see, that's terrible, but nerve root would be coming like this. Let me start that over. Goodness sakes. Should have took that break. Nerve root would be coming out something like this on each side. But then you also have traversing roots, which would be going down and coming out down here below. So the back of the disc, where it's the weakest and incomplete, is right in this kind of danger zone, if you will. So that's not a good place to be weak and incomplete. So herniations can occur right in this region. We'll look at herniation here in a second. Just an overhead view again, showing the disc, nucleus. In reality, the nucleus, there's like this kind of transitional area where it's kind of semi-nucleus and semi-annulus fibrosis. Cervical disc pathology. So a disc can rip, we'll look at this here in a second, and create discogenic pain from an annular tear. The annular tear can progress into a herniation where the disc material squeezes out the back and compresses those nerves I just drew. And that can cause pain down the arms. That's called radicular pain. It's not called radiculopathy. Radiculopathy is a neurological finding. You've tested reflexes and muscles. You've found a loss of reflexes, a loss of muscle strength. You make the diagnosis of radiculopathy. The pain that radiates, the adjective, is radicular pain. One of my pet peeves, right? You can also have problems with ligamentum flavum. Did we look at that? I think we did look at that. Bulging and compressing those neural structures, resulting in radicular pain. Or central stenosis. You can have myelopathy, neurogenic claudication, and things like that. So here's a little cartoon I whipped up. There's a young, healthy-looking disc. There's the nucleus annulus. Remember, the lamellae, which I didn't draw in, are weak here in these corners, right? So you don't want a herniation coming right here, right? Because that's where the delicate nerve roots are. The rootlets and the sensory and the motor nerve roots are right in this region. Dorsal root ganglia is fairly well protected because of the uncinate processes, but this region is not. So what's the first thing that happens in the birth of a annular tear and herniation? I could have entitled this. First thing is you get a degenerative disease. Maybe you have a scoliosis. Maybe you have weak muscles. Maybe you're in a car crash and your ligaments are loose now. Now your biomechanics are screwed up and you got degenerative disease of the disc. It gets weak, dried out, and brittle. Cells have died and they don't make proteoglycans anymore. So what happens next? Now you got yourself, let's say you got in a little fender bender, in the parking lot, something minor, and you ripped your disc open. That can be super painful and necessitate an ACDF fusion or some other type of procedure. People can have these without any pain. It's all, I didn't draw this in, but it's all about these little guys. In the back of the disc, remember from my other videos, you have sinovertebral nerves, right? Just in the outer portion here. If you get this degenerated stuff and it starts to cause an inflammation in here, possibly because the cells in here were developed after the formation of the nervous system. I won't get into that now, but it's weird because when you're born with notochordal-like cells, but they morph into more fibroblast-like cells by the time you're about 10. One theory is the body doesn't know who they are. And if you get a rip out here where the nerves are, the blood vessels are also out here, right? The disc is avascular, you know from my lumbar videos. But if this degenerated gunk gets in here filled with cytokines like tumor necrosis factor alpha, you can get a wicked inflammation here. And that's called discogenic pain. It seems to be rare, but some people can even leak. These tears can leak. And it can cause a chemical radiculopathy by causing an inflammation inside these nerve roots here. So that can happen as well. But that's called a full thickness annular tear. Got to get a drink of water. And that may or may not be a source of pain. It all depends if inflammation has occurred there. What it can do, though, now if you have a big degenerative chunk of nucleus pulposus, you can deliver that like delivering a baby. And that's what happens next. This is a disc herniation, where the nucleus pulposus has pushed out. And yeah, you got yourself a herniation. Compressing the nerve rootlets and the motor nerve root here. Not the dorsal, but yeah, if that gets inflamed, the patient's got horrible pain going down the arm. I guess this would be, usually that would be the right arm. These sides are usually reversed. But yeah, they'd be miserable. And if it's bad enough, they might have motor loss and reflex loss, and they might have real radiculopathy. All right, last thing I just want to mention is the C7 vertebrae, because I have in my practice seen these things. C7 is not quite as strange. It has that long bifid spinous process called the vertebral prominens. But another weird thing about C7, it's got a hole for the vertebral artery, but in most people, the vertebral artery doesn't go through the hole. That's really weird. But the vertebral veins do go through the hole. So very strange. Vertebral artery usually goes in the transverse foramen of C6. So very weird. 75% of the time, this is the longest bone, the one that sticks out the furthest. About 15% of the time, it's T1. 10% of the time, it's C6. That's not why I'm putting this in here. These darn cervical ribs or hypertrophic transverse processes, you're going to run into these when you get out in the field. So you need to know something about these. So if the transverse processes extend further out more laterally than those of T1, you got yourself something called hypertrophic transverse processes. Even weirder, sometimes you can grow a rib off the transverse processes. Really weird, called cervical rib. I guess I should have talked more about the thoracic outlet, but these cervical ribs or hypertrophic transverse processes, they can compress the inferior trunk of the brachial plexus, mainly the C8 root. And you can get an ulnar neuropathy because of this. You can get pain burning down your arm. You can lose some function in your hand. It can be quite pesky. It can also compress the subclavian artery, and it could cause a blood clot. Luckily, the blood clot won't go into the brain. It goes down toward gets stuck in the hand or something. Sorry for the noise again. We did pretty good, except it's getting a little noisy out there. So that's called thoracic outlet syndrome. So bottom line, cervical rib or hypertrophic transverse processes can cause thoracic outlet syndrome, which is the worst darn name in the world, right? Thoracic outlet is down by your stomach. That's the thoracic inlet, yet they call it thoracic outlet. Absolutely horrible anatomical term. Been fighting with clinicians for years to change it, but it's never going to get changed. So we got a 37-year-old electrician comes into your office with neck pain, numbness, tingling, burning in his right upper extremity, especially when he works overhead. You take some radiographs. What do you think? As we listen, I don't know if you guys can hear that or not. Got some guy sawing or something out there. Sorry about that. This is not the guy, right? This is normal. So here's T1. There's the T1 transverse process here. T1 transverse process here. And then we have pretty close to getting but there's transverse process of C7 is here and here. And it's okay. Okay, but let's look at our patient now. Here's our patient. Oh my gosh, that's like ridiculous, right? You can see that. So here's the C7 transverse process right here. And he's got this little bump growing here. That's called a cervical rib. It's even worse on the other side. Right? So those are cervical ribs. How about this one? Or there, I pointed them out for you. How about this guy? 62-year-old comes in. Trouble working overhead. What's the problem? Oh, yeah, look at these. Yeah, good. You got them. Right? But this time there's no little bump. Right? They're hypertrophic. You have to know the difference between cervical rib and hypertrophic. They're very important. So those are hypertrophic transverse processes. They both do the same thing. The C8, or the inferior trunk of the brachial plexus, comes right out here, and so does the subclavian artery. So you bend and you extend your head. I mean, that could come down and crush those things. So you get your hands fall asleep, and there are all sorts of symptoms. I won't get into that now. All right. Did we do it? Yeah, we did. All right, awesome. We made it through here. You are now an expert on the cervical spine. If you know all this stuff, my students can be tested on this stuff. I don't know if I'll make them watch this or not. But you're definitely ready to go into the how to read your MRI now that you know all this anatomy. All right, so give me a thumbs up if you like the video. Subscribe to the channel. We'll see you in the next one.